All right, I think we have a quorum and we'll get started. So good afternoon or good evening or good morning, depending on where you all are. My name is Imran Hassan. I'm full disclosure, I'm a colorectal surgeon. The only reason I'm here today is because Rohan is in India meeting his son's in-laws. So he couldn't be here because of the time difference, although he did text me a few hours ago to make sure I was going to show up and make sure things moved along. So welcome to everybody. This Grand Rounds is on achalasia, which we presented by Dr. Pandya from the Swedish Medical Center. Dr. Lee Swanstrom is our guest speaker, and again, he doesn't need no introduction, but we're really privileged to have him, and I'm sure he's a leader in the management of foregut conditions such as achalasia, and I think his insight will be very insightful and his opinions. And the rest, we have some faculty here and we have some fellows here. And I have to be honest, I don't know everybody. I recognize some names. So if everybody can just quickly go introduce themselves and just tell them who they are, I think that will be helpful. And we can then get started in a couple of minutes.
So thank you, Imran. Maybe I'll start.
Sure.
As you mentioned, I'm Lee Swanstrom. I'm a foregut surgeon, currently at the University of Strasbourg in France, and have a long time in the Northwest part of the United States as well. So I'm happy to be assisting Tejal during her presentation.
Hi, how are you? I'm Sam Chosra from Mexico City. I'm a general surgeon, and I'm just listening with interest, of course, what they're going to do, all your residents, but especially to listen to Lee Swanstrom, that for sure he will bring something new. Thank you.
Good to see you, Sam.
Tejal, do you want to introduce yourself?
Sure, thank you. My name is Tejal Pandya. I'm the Foregut Fellow at Swedish Medical Center in Seattle, and I'll be presenting today.
Maybe Peter. Peter's on.
Yep, I'm here. Hi, I'm Peter White. I'm one of the partners at Swedish Medical Center, although Dr. Bograd, I think, is on as well as the assistant program director. Dr. Farivar couldn't make it, who is the program director, because he's in a colon interposition case at the moment, but happy to be here to support Tejal.
All right, thank you very much, Dr. White, for being here.
Hi, Adam Bograd. I'm one of Tejal's attendings. I'm a thoracic surgeon here at Swedish as well.
Okay, thank you, Dr. Bograd. And I recognize Michael Jureller is, I think, one of Rohan's current fellows. And to be honest, I don't recognize any other names, but we can get started. Dr. You have the floor or the screen.
Okay, thank you. So good afternoon. Like I said before, I'm Tejal Pandya, and I'm talking today about achalasia, and I'm going to focus particularly on evaluation and surgical management. I don't have any disclosures. So here's a roadmap for our discussion today. I'm going to begin with some background information about achalasia and initial evaluation. This will include some adjunctive testing. Next, we'll review surgical therapies and ideas surrounding optimizing them. And finally, we'll compare the options based on different measures of success and discuss how to choose an operation. So achalasia is a motility disorder defined by reduced peristalsis and obstruction at the lower esophageal sphincter. There is no cure. Treatment is focused on palliation, specifically symptom relief and delayed progression of esophageal changes. It is rare, with an incidence of 0.5 to 1.5 per 100,000 and prevalence of 8 to 10 per 100,000 in the Western world, and there is no special gender or race predominance. There are many potential pathways to developing achalasia, including viral infection, autoimmune, or familial inheritance. However, once the process begins, the end result is the same: inflammation and injury to the myenteric plexus of the esophagus, and loss of the nitric oxide secreting relaxing neural cells at the lower esophageal sphincter. This leaves only the acetylcholine secreting contractile neural cells, resulting in a tonic contraction. This is the mechanism of the classic loss of receptive relaxation and aperistalsis that together characterize achalasia. So I wanted to start our journey today with an illustrative case. This is patient JC. He's a 58-year-old gentleman with 6 years of progressive symptoms prior to presentation to our office. Originally, he began with choking and vomiting of food and had a sense of food stacking up during meals. Proton pump inhibitors were not helpful. Over time, his meals became smaller, and yet they lasted longer. He also began to eat earlier in the evening to minimize his nocturnal symptoms, which included spitting up food at night despite sleeping on a wedge pillow. So JC has some mixture of symptoms that are common to achalasia, but also to other foregut disorders. You can see that he was trialed on PPI by previous physicians, likely in an effort to treat or rule out reflux. In this table, you can see common foregut complaints and their frequency in achalasia. Younger patients are more likely to have chest pain or heartburn. Obese patients can have more frequent choking or vomiting. And a broad range, up to 91% of patients might report weight loss, somewhere 5 to 25 pounds. Their predominant complaints give us a place to start their evaluation. There are some historical features which may make us more suspicious for potential achalasia. The challenge is that many patients grow accustomed to their unusual habits over time, and they don't really realize to report them. So here in this table, I've categorized areas of difficulty that patients may have that we want to draw out during our questioning. They have to pace their meals by their perceived esophageal clearance. This means grazing or minimizing meal sizes. They may always be the last one at the table, or never really finish a meal entirely. They also may interrupt their meals to do physical activities like pacing or hopping. Some patients report flushing down each bite or doing some pressurization of the esophagus, either with fluid or other means, to push the food down. And with this, some patients report a sense occasionally that a trap door has opened, that periodically, all of a sudden with these maneuvers, things will move through and the esophagus will clear. Despite all these maneuvers, regurgitation is an issue, and they may be spitting into their napkins during their meal or going to the bathroom in the middle of the meal. Some of them have nocturnal regurgitation, and others may instead or also report aspiration or pneumonia. Ultimately, all of these things also result in lifestyle changes like avoiding restaurants or eating in public and alteration of sleeping positions. And then the other thing to know is that sometimes they don't really realize these things at all. And it's up to the family members who may be noticing to report them for you if they come with the patient to the office. So in the setting of dysphagia or questions about esophageal clearance, our first study is a time barium esophagram. This is a standardized and more thorough exam compared to a standard esophagram. Patients drink about 200 milliliters of barium, and images are taken at 1, 2, at 5 minutes. The width and height of the barium column are measured, and most normal patients will have cleared the barium by 1 to 2 minutes, but certainly by 5 minutes. Additional materials like a 13 millimeter barium tablet and oatmeal are used at our institution to provide even more detail about how the esophagus is able to handle different textures, as well as to assess areas of narrowing or significant contour obstacles. The timed barium esophagram can be followed before and after therapy to verify success. For example, in one study looking at Heller myotomy patients, they found that most patients had improvement in their barium clearance post-op, and those that required re-intervention had higher height and width of their barium column at 5 minutes post-op. Specifically, they noticed that a persistent barium column with a width of more than 3 centimeters at 1 minute during their 8-week post-op time barium esophagram suggested a higher probability for the need for re-intervention later on. So here you can see the time barium esophagram for our patient with findings that support achalasia. The esophagus is wide and there's a clear bird's beak. There's tortuosity, and there's also retained barium at 5 minutes. In our practice, all patients are subsequently taken to endoscopy by us. This allows visual and anatomic assessment of the esophagus. It might be seemingly normal or reported as normal at an outside facility when you get a referral. But features that are supportive of achalasia include retained food or saliva, mucosal changes related to stasis, dilation or tortuosity, and potentially a puckered GE junction, which may require some pressure or a pop to get through. It's important to use endoscopy to rule out pseudoachalasia, which could be an obstructive lesion or a cancer around the GE junction that might produce similar symptoms. The concern for this is more in older patients, those with more rapid onset of symptoms, and significant weight loss more than 25 pounds. 2 to 4% of potential achalasia patients may actually have a cancer. So if something is not clearly seen intraluminally and there's still a concern for an extrinsic or intramural lesion, a different testing pathway can then be pursued, like EUS or CT scan. So these are the endoscopy images for our patient. You can see there's a tight lower esophageal sphincter here with maybe a little bit of trauma there with the scope passing through. The esophagus is wide with retained saliva. And here is some tortuosity that was seen on the esophagram as well. So ultimately, manometry defines achalasia, and it is required for the diagnosis. The Chicago classification, currently in version 4, is a set of manometric definitions for motility disorders using high-resolution manometry, and it is published and updated periodically by a multi-institutional group of collaborators. So let's look for a moment at a normal swallow on manometry, which is here on the left. This is measuring pressure over time as a bolus of water is swallowed down. The top and the bottom shows 2 pressure bands representing the upper and lower esophageal sphincters. These remain solid until they are interrupted or relaxed by a swallow. So after the upper esophageal sphincter opens here, we can see that the lower esophageal sphincter shows receptive relaxation. The peristalsis progresses with time in this diagonal pattern, and all of this happens in a reasonable amount of time, such that the bolus actually gets time to pass down into the stomach. Achalasia has 3 defined subtypes, and you can see that they do not resemble a normal swallow, except perhaps type 3 might at first glance. They are collectively defined as having no peristalsis and no LES relaxation, which is measured by the parameter IRP, or integrated relaxation pressure. So you can see here, none of the subtypes show a gap in the LES tracing. Type 1 has no esophageal pressure at all. Type 2 shows pan-pressurization or columns of pressure which are not peristaltic. And type 3 is characterized by an overly rapid onset of esophageal contraction. It is too fast here, less than 4.5 seconds, which is the definition of a spasm on manometry rather than peristalsis. So here in type 3, this spasm is the reason why chest pain is a more common symptom here than in the other subtypes. So this is our patient's manometry, and you can see that he was diagnosed with type 2 achalasia. In fact, when he went for his manometry, he had difficulty tolerating it, and he had to come back to endoscopy for assistance with catheter placement, which itself gives us another clue in favor of some kind of obstructive disorder, even before the manometry is done. So sometimes manometry is not clear-cut, and the findings don't match all the defined parameters, even when there's a strong suspicion for achalasia. There is ongoing study regarding the relationship between motility disorders and whether in some cases one can evolve into another defined disorder. For example, some patients may evolve from type 3 achalasia to type 1 over time as the neural cells continue to degenerate. So in the midst of that process, a manometry may not fit a clear diagnosis. Some of the common challenging scenarios include type 1 achalasia pattern, but with normal lower esophageal relaxing pressure. Others include variations of spastic or obstructive disorders. And finally, it's important to realize that opioid use can produce spastic changes on manometry that mimics type 3 achalasia. So it's important to test patients off opioids. So here are a couple of examples of other spastic or hypercontractile disorders that can resemble type 3 achalasia. In distal esophageal spasm, the contraction is too fast, but the LES does relax. In EGJ outflow obstruction, the LES does not relax normally, but there is normal peristalsis. The trickiest one may be EGJ outflow obstruction, but with spastic features instead of peristalsis. In these type of situations, the importance of the constellation of studies that support the diagnosis of achalasia becomes even more important. So with all of these evaluation, if the diagnosis of achalasia is clear, then pH testing is not required. However, at times it may be relevant to rule out GERD. Some of the spastic changes seen in other disorders may be secondary to acid reflux, and pH testing can help us clarify. The pH can be elevated in achalasia patients due to fermentation of retained food, but the pattern is different from acid reflux. And it's more likely, like the one here on the right, to be a slow and gradual acidification over time, as opposed to intermittent sharp spiking like we see in acid reflux here on the left. And then finally, a device gaining broader use for adjunctive testing in motility disorders is FLIP, also known as EndoFLIP. It stands for Functional Luminal Imaging Probe, and it's comprised of a series of pressure sensors on a catheter, which is centered inside a balloon that can be inflated to various volumes with saline. The device takes advantage of electron flow or impedance, and when the balloon contacts the esophageal wall, it allows dynamic pressure measurements along the whole length of the catheter, producing real-time images like the one here on the right. The device calculates various parameters which are listed here. The value and the best use of the various measures is still under investigation, but the most commonly followed parameter is the distensibility index. And in achalasia, this is usually less than 2.9, which is something we will come back to. So FLIP is also being used to assess motility patterns, and certain findings have been found to correspond to each of the subtypes of achalasia. Here you can see the top row shows the FLIP image, and each one shows some resemblance to the high-resolution manometry image below it. FLIP can assess the contraction patterns and response to distension, and so it produces additional and dynamic information compared to manometry, which can help further clarify the diagnosis. So now we've kind of reviewed the background and physiology and initial evaluation, including tests that we can use to help us clarify the diagnosis when it's more challenging. And so now I'd like to move on to surgical therapy. So just to take a bird's eye view for a moment, you may recall that achalasia has medical and procedural treatment options. The procedural options are essentially different methods to achieve a myotomy across the GE junction, which are both surgical and non-surgical. So we are going to focus on the surgical options. So we have to remember that throughout our approach to an achalasia patient, that our goal is palliation. We cannot make them normal. We can only make them more functional and less symptomatic, with the hope that whatever progressive changes to the esophagus that would normally occur can be slowed, and any adverse effect of our intervention is not too great. So here's a table showing end-stage changes in achalasia, which we hope to avoid. At this stage, patients might ultimately be best served by esophagectomy, which is a last resort, and it's employed in about 5% of achalasia patients. Laparoscopic Heller myotomy is the gold standard operation, which produces durable relief from symptoms and obstruction. The goal is to entirely cut through the lower esophageal sphincter, full thickness. In our practice, we create a 6-centimeter myotomy, 4 centimeters on the esophageal side and 2 on the gastric side. There are a few key points with this procedure. First, it's important to cut perpendicular to the muscle fibers to get completely through them. Not doing this is the most common cause of incomplete myotomy. If the patient has a hiatal hernia, this needs to be dissected and repaired. And finally, the operation typically includes partial fundoplication. We prepare the patients 2 days in advance with a liquid diet to help clear the esophagus and a nystatin solution. At the time of surgery, the patient is intubated with the head of bed elevated and rapid sequence intubation is used. So here's some illustration regarding Heller myotomy. This diagram shows the geometry of the LES fibers and specifically the oblique orientation of the sling fibers that we need to address. The myotomy, which I've drawn here in orange, must be perpendicular to these, taking a hockey stick configuration. So you can see here that continuing down from the esophagus vertically onto the stomach would not help us achieve an adequate myotomy. We routinely perform EGD at the end of the procedure to ensure there are no mucosal injuries that need to be repaired and to assess for any remaining muscle bands that need to be addressed. We complete the operation typically with a door fundoplication. Many prefer the anterior 180-degree door because it allows the exposed mucosa to have a buttress and it can help create a seal in case of any mucosotomy. It produces less dysphagia compared to other fundoplications, and it does not require a hiatal dissection to construct, but it is the least robust anti-reflux valve. The toupee requires a hiatal dissection to place a posterior 270-degree wrap. If this is not already required due to hiatal hernia repair, it does add operative time. But still, some prefer this because the edges of the wrap can be secured to the edges of the myotomy, thereby everting it more and avoiding it healing in a closed position. And some people prefer it because it is a more complete anti-reflux valve. For our practice, regardless of partial fundoplication choice, upon completion, we keep all patients NPO until an esophagram is completed the next day, showing good emptying and no leaks. The patient progresses to a full liquid diet, which they stay on for 1 week, before progressing to soft and then regular diet. They take liquid or crushed medications for the first 2 weeks, and they remain on PPI until follow-up testing. So in 2004, a randomized control trial regarding Heller myotomy patients with and without door fundoplication was conducted, and it showed us that the reduction in acid exposure to the esophagus was substantial with the addition of a door. Importantly, it also clarified that this did not increase dysphagia postoperatively, which is one of the concerns that some people had. More recently, in 2012, another randomized control trial sought to compare both partial fundoplications based on symptoms or physiologic testing for looking for differences when used with Heller myotomy. They hypothesized that the toupee would result in less 24-hour pH test abnormalities. Of the 60 patients available for analysis, 71% underwent the post-op pH testing at 6 to 12 months. And despite the challenges in follow-up, they were ultimately able to conclude that there was no significant difference in post-op pH results, with all of the patients showing normal Demeester scores. So with all of this information, ultimately the type of partial fundoplication does rely ultimately on surgeon preference, but certainly patients do benefit from having it rather than not. So now we've discussed the gold standard operation, and we can move on to a newer option. The POEM procedure was first documented in humans in 2010, and since then it has grown in use substantially. It is entirely endoscopic method for myotomy across the GE junction. It does not disrupt the hiatal attachments, and it can be helpful in a hostile abdomen or in those people who cannot tolerate abdominal CO2 insufflation. So the procedure begins with an EGD to empty the esophagus and also to take measurements relative to the GE junction. While many advocate a longer myotomy, especially in type 3 achalasia, we here routinely plan the myotomy to span 6 centimeters, just as we do with the Heller myotomy. 2 centimeters on the gastric lesser curve, which is the endpoint is marked with blue dye, and 4 centimeters proximal on the esophagus. The myotomy is achieved in the submucosal space, and a mucosotomy is planned 5 centimeters proximal to the intended start of the myotomy. So we have 5 centimeters of normal overlap. So here are the key steps to POEM. We start with the mucosotomy by creating a saline bleb prior to incision. The endoscope is then fitted with a dissection cap, and a combination of blunt, cautery, and hydrodissection is used to expand the plane and create a submucosal tunnel down to our endpoint on the gastric side. Once the tunnel is complete, we perform the myotomy of the inner circular fibers from proximal to distal. And at completion, we employ double endoscopy to verify, with one endoscope in the submucosal tunnel and one in the normal lumen to ensure that the orientation of the tunnel is appropriate and verify that we reached our target endpoint. Once we're completed, the mucosotomy is closed with clips, and our pre and post-op care of POEM patients is the same as our Heller patients. So as with all achalasia treatment, a balance of symptoms, obstruction, and new challenges is sought. Heller myotomy has come to be fairly reliable in its application and length, with some variations across surgeons. But of course, with any new tool, POEM is being applied with more broad variety. For example, variable lengths of the esophageal myotomy are advocated, and some people specifically use the manometric height of the spasm to guide the myotomy length in type 3 achalasia. Part of the attraction might be that this thoracic extension was technically more challenging with laparoscopy. And there's also a desire, of course, to maximize the potential myotomy benefit. So EndoFLIP continues to be actively investigated as a tool to optimally calibrate myotomy, especially POEM, and ensure adequate muscle release. We use it routinely during the procedure, pre and post myotomy, looking for changes in the distensibility index in particular, but also the diameter and the cross-sectional area. Currently, standardized protocols for data collection are pending wide adoption, and normal values are still being clarified. The trouble, too, is that while achalasia patients all have a clearly established functional problem, there seems to be some variability amongst patients regarding baseline EndoFLIP measurements. So what we use as a standard currently doesn't seem to always apply to every patient. Despite that, there are some established benchmark measurements currently providing us some guidance. After study of normal individuals, a minimum distensibility index of 2.9 at the GE junction is currently accepted as normal. And after studying both Heller myotomy and POEM patients with EndoFLIP, one study found a suitable DI range for the completion, after completion of the myotomy, which balanced out esophagitis and persistent subjective symptoms. And that range was the 4.5 to 8.5 number that we have here. So it's important to recognize that not all of the patients will meet these parameters after treatment, and yet they might report successful subjective scores postoperatively. There's some investigation into whether a delta or a change in the distensibility index could be a more useful target rather than absolute measurements. But these are issues that are still being clarified. And then historically, of course, EndoFLIP was not being used to create Heller myotomy, but now it's being applied for this as well in some centers. One study looking at the change in distensibility before and after fundoplication, and they saw that the improvement in the distensibility after the myotomy did reduce a bit with the fundoplication, but ultimately still left the patient in an improved position. So these are our surgical options for achalasia that we've kind of been able to go through. And I wanted to finish with comparing them and ultimately choosing an option. So recently, a meta-analysis of 20 papers was published looking at the therapeutic options relative to manometric subtypes of achalasia. Here we can see all of the options for treatment, but we'll focus on the operative ones. Type 1 showed reasonable success with both operations, but more so with POEM, with an odds ratio of 2.7. Type 2, as reported in many publications, generally responded the best to all forms of treatment. And type 3 was noted to do significantly better with POEM with an odds ratio of 3.5. It is important to notice here that in the type 3 group, the POEM myotomy length was much longer than the myotomy used in the Heller operation. In addition, it's important to note that most studies use subjective questionnaires to define success, with some variable objective follow-up as well, depending on the study. So symptoms and response to treatment are most universally followed with the Eckhart score. This contains the most common symptoms in achalasia, and it's scored from 0 to 12. The goal is to keep the patient less than 3 in response to therapy, which is the number that defines success. This can be followed over time, and if the score rises, additional evaluation is warranted. But notice here that it's entirely subjective, other than kilograms of weight loss. So it's important to realize that subjective questionnaires do not capture all of the true objective changes going on after myotomy in an achalasia patient. One study following up on Heller patients up to 30 years later showed that most of them had continued excellent results, but an important proportion of them ultimately failed primarily due to reflux. And these were identified by objective pH testing. Only 47% of the patients had a normal Demeester score when beyond 20 years from their original operation. And some of them began to show metaplastic changes in the distal esophagus as well. This shows us that even with a durable operation, over time, patients do develop important clinical changes. And these are best captured on objective testing like pH scores and endoscopy. These kind of long-term results are not available for POEM yet. But here's one study with a 6-year follow-up, which is pretty long for a POEM, and showed that even in those with good results, which was defined as an Eckhart score less than 3, a large proportion of them, around 40%, had some indication of reflux disease that caused them symptoms or required treatment. So this is in line with other studies reporting somewhere 40 to 60% of patients after POEM having some degree of reflux. And the previous meta-analysis that we talked about also noted in their discussion, importantly, that GERD was not very clearly or consistently assessed postoperatively in the various studies. Some used only subjective measures, others endoscopy or evidence of esophagitis, and others used the pH scores. In their analysis overall, they found 47% of POEM patients had some evidence of GERD, and they concluded that it would be appropriate to offer all POEM candidates a Heller myotomy when counseling them on their options. So subjective assessments matter because it gives us an indication of how the patient feels she's doing and can suggest to us when the quality of life is suffering, which is one priority of our palliation in achalasia. But we can see that these do not give us the whole picture of issues that we as surgeons need to address over time to fully care for the patient. In our program, we've taken a report card approach to post-op follow-up. We essentially collect a similar constellation of data as with preoperative testing and take the various factors into account when formulating an ongoing plan or knowing when to offer a new intervention. Here's a study where our group looked at 185 patients over a median of 20 months of follow-up. 71 of them were POEM patients and 114 of them were Heller patients, mostly with door fundoplication. The definition of success in each particular evaluation tool is listed beside it on the table here. And in each column here, based on the operation, you see the percent of patients who achieved success in that parameter. As you can see, almost all of the patients were successful based on their Eckhart score, but yet the results varied widely in the other subjective and objective parameters. So this means that even as the patient is feeling fine, there are underlying changes occurring. So this is the schedule that we employ for data collection on patients postoperatively. Compliance can be challenging, especially if the patient is doing well, as we saw in the randomized control trial comparing tupé and door fundoplication. So this means that the initial and ongoing counseling that we as surgeons must impress upon the patient the incurable nature of their disease and the potential later-term problems that they could develop. This discussion helps guide patient preference of operation But it also normalizes their expectations about ongoing evaluation and the possibility of additional future therapy, and the need for them to engage in our postoperative ongoing evaluations. So based on these practice patterns, some observations have emerged in our practice. First, notice that operations are not preferentially offered based on manometric subtype, but rather on counseling and a combined decision-making with the patient. As a result, we have data on all subtypes receiving either Heller myotomy or POEM. Both operations are also done with the same standard 4+2 centimeter myotomy technique as a standard, with no real variations. In general, most patients reported normal Eckhart scores, which would define success usually. And using our report card approach, we found that less than half of the patients reported actually normal swallowing subjectively. Time to barium esophagram shows variability, but it shows the poorest clearance in type 1. The GERD scores are variable, but best in type 3. And pH testing is normal in an average of 50% of patients, regardless of their subtype. So without preferential application of surgical options based on subtypes, most patients feel fine and seem to have similar objective findings postoperatively in our practice. And so this information raises a question about the obligatory use of POEM in type 3 achalasia, and also the necessity of a long myotomy in these patients. So here's a randomized control trial asking some similar questions. They studied 100 patients up to 1 year post-op, and each patient was evaluated initially with high-resolution manometry, endoscopy, time to barium esophagram, the GERD HRQL score, and the Eckhart score. They performed either a 5.6 centimeter or a 10 centimeter myotomy. Endoscopy was repeated at 6 months and 1 year, and high-resolution manometry, time to barium esophagram, and pH exam were done at 1 year. They found that the short myotomy took significantly less time to perform by about 15 minutes and showed less abnormality in post-op pH scores. So this supports our internal experience as well with the standard 6 centimeter myotomy for the POEM, and shows that the shorter length does minimize acid exposure to the esophagus with similar subjective success for the patient. So our group sought to understand this myotomy length issue further by studying patients with EndoFLIP during incremental myotomy, 2 centimeter length at a time, up to the full 6 centimeters that we usually perform. They started at the LES, then the 2 centimeters on the gastric side, and then finally the 2 additional on the esophageal side. You can see in this graph that the distensibility index measurements after each step, and there's generally an increase at each point. Ultimately, 50% of patients achieve the target distensibility index with only the 2 centimeter initial myotomy of the lower esophageal sphincter itself. And there was a statistically significant change in the distensibility index from baseline when performing up to only the 4 centimeter myotomy. So this suggests that somewhere between 4 and 6 centimeters may be sufficient for most people. And more study on minimizing the myotomy length might actually provide us with a better balance of outcomes that we seek for the patients. It also shows us that there is perhaps some individualizing of the myotomy length that we could be doing in the future. So with all this information, and some of it seeming contradictory, how do we choose an operation for the patient sitting in front of us in the office? First of all, we have to take into account fundamental patient factors that preclude one or the other operation. So, for example, in POEM, you might favor this procedure with a patient with a hostile abdomen or an inability to tolerate CO2 insufflation. You might prefer Heller myotomy and fundoplication in those with a challenging contours to their esophagus, making POEM more challenging for those who have a hiatal hernia, perhaps. And then there are those who maybe have had radiation, ablation, or other fibrotic changes to the esophagus, which makes it difficult or impossible to create the submucosal tunnel that's required. And then those with cirrhosis or bleeding disorders are not appropriate for POEM, and Heller myotomy might be favored. So if these are not an issue, we counsel patients about both options and their potential rates of success with those options. We further explain the necessity and importance of the ongoing follow-up and the potential for reflux, need for reflux treatment required potentially over time, depending on their choice, and the potential for PPI dependence later on. As the knowledge on the evolution of motility disorders from one to another and the longer-term outcomes of POEM are better understood, until that time, we tend not to prefer POEM for younger patients, opting instead for better reflex control that the fundoplication offers when we perform Heller myotomy. So we've finally arrived at the end. To review, we've kind of covered the background and pathophysiology of achalasia, the evaluation and adjunctive testing, and we discussed the surgical therapies and ways to optimize them. And then finally, we talked about comparing the options and their success and discussed our thinking behind offering an option to patients. So to conclude, achalasia requires both a lack of peristalsis and a lack of receptive relaxation for diagnosis based on manometry. Achalasia can only be palliated, not cured. And clarifying a diagnosis may not be very straightforward. EndoFLIP continues to refine as a diagnostic and therapy guiding tool. And there is still more to learn about optimizing Heller or POEM and the implication of the subtypes. Postoperative acid reflux is still a big challenge, and it can result in Barrett's changes. And a longer myotomy may not be better in type 3 achalasia. And instead, maybe further study is required about shorter myotomy. And then ultimately, objective and routine postoperative evaluation can reveal outcomes and needs more specifically than just subjective tests alone. So thank you for your attention.
That's great, Tejal, a great presentation, nice summary of everything from diagnosis to treatment to follow-up. And certainly all those things are necessary if you're going to take care of these patients. I don't know if anybody else has any questions. Not, I may ask you one about the type 3 achalasia. So your group has published a paper that kind of indicated that a short myotomy might be equally good. Is that kind of your common practice now, or do you still tend to extend the myotomy a little bit proximal because it's so easy to do with POEM?
You mean, so our standard here is to employ the same 6 centimeter length that we traditionally always have for Heller myotomy, and that hasn't really changed. So that includes 4 centimeters on the esophagus and 2 centimeters onto the gastric side. We have not made any variations or standard changes to shorten that more specifically further when we employ EndoFLIP during POEM. And I think, you know, we have this that we published about this idea and kind of exploring. But, you know, when I was looking around in the literature about some of these questions, it's challenging to find corroboration. And I think, you know, one of the things as a surgeon, really makes your heart sink is when you go in to do you know, create an alteration that hopefully moves the patient a substantial step forward in either how they feel or how they perform, and then they have what turns out to be an incomplete myotomy and they're kind of still in the same place. So I think pushing that shortening of the myotomy hasn't really fully materialized in a standard way quite yet for us.
I have to say that we have adopted that, and our length of myotomy has decreased over time, and we have seen a corresponding decrease in the incidence of pH positive results afterwards. So I think it's a little bit hard to know how short is too short. But that remains to be seen. But I think you're right. EndoFLIP may provide some of the answers.
Dr. Pandya, thanks for a great talk. Dr. Swanstrom, again, thanks for your comments. One of the parts of this seminar is to have interaction and get opinions from everybody. So we have about 10 to 15 minutes. I'd like to make sure everybody kind of has any other comments, because there's more than one way of doing the same thing. So as I said, I'm a colorectal surgeon, so I'm kind of shooting from the hip here. But the length of myotomy, so Dr. Swanstrom, you had mentioned that you've decreased the size of myotomy in your practice. So what dictated that, and kind of how did that evolve? And then maybe you could make some comments on POEM, since you've kind of seen the whole evolution of that developing, and where do you think, what role that is in your practice and in general?
Yeah, it's a great question. I think really, as Tejal said, EndoFLIP has changed kind of how we do our practice. It's a nice intraoperative measure on what you're doing. Luke Hill from the Swedish group kind of was a pioneer of intraoperative manometry, which is messy and difficult and not easy to do, but EndoFLIP is quite easy to do, and really has altered our practice quite a bit. So I'd say it's based on intraoperative measurements that led to the changes, and because reflux is a problem after myotomy with fundoplication or POEM. It's not a good thing for patients to have long-standing reflux disease.
And with POEM, where does that stand in your practice? Do you think, it seems like Tejal was saying that it's a kind of an either-or choice. Do you think that POEM has a definite, I mean, it does have a definite role, but where does that fit in your algorithm of managing these patients?
We rather do the same. We love doing myotomies, but POEMs are fun as well. So we pretty much have equipoise in proposing either solution to patients. I have to say, left to their own devices, patients tend to want a POEM. They perceive that as less invasive, less risky. So probably the majority of what we do is these days is POEM, but that's based on patient choice.
Okay. And do you think, and if correct me, does EndoFLIP also work in POEM also? Can you use EndoFLIP while you do a POEM?
Certainly, you can. There's two ways of doing it. Some people leave the EndoFLIP in during the POEM, since you're submucosal, doesn't really interfere with that. Others do intermittent measurements throughout the procedure. So Tejal showed a nice paper of doing intermittent POEM recordings of when you do the tunnel, and then when you start the myotomy in the esophagus, when you start the myotomy across the LES and extend it in the stomach, of seeing the changes in real time using that.
Okay. There's a question in the chat, and I have to be honest, I'm not sure if I know the answer, so I'll leave that up to you. That is, anyone any experience in laparoscopic cardioplasty following recurrent achalasia after a Heller's? And I have to be honest, I don't know what a cardioplasty is either.
I'm not sure what they're asking quite either.
That's okay. So it's a question about recurrence. So how do you handle, Dr. Swanstrom, when you have people who recur after a Heller's or after a POEM? What's the approach to them? Do you redo the POEM or the first operation, or do you switch to the other operation? And maybe Tejal can start with, maybe you can ask her first, and then Dr. Swanstrom can add, or anybody else who wants to comment on that. How do we manage recurrences depending upon what technique is used the first time around?
I think, Tejal, maybe you can tell how you would work those patients up.
Sure. So we, you saw our report card concept. We work up the patients. Hopefully they come back to us routinely and we keep up with that habit. But even if they don't, we take that whole comprehensive approach to looking at them from scratch, basically. So that means endoscopy, manometry, time barium esophagram, and pH testing. Ultimately, if it seems appropriate that they need a reintervention based on all of the findings, usually we start with dilation and give them an opportunity, more than one setting if necessary, if they don't get improvement after the first intervention with dilation, to see if that will be adequate enough, or gives them at least some duration of relief. And so then you can take that information into account too about what might be happening. Because there's one thing I've come to understand this year is, you kind of have to do a lot of imagination, like you take all these constellation of studies and then you have to imagine, like, I'm the lower esophageal sphincter, what's happening to me, and so how can we proceed with that? So if it turns out that the patient needs an operation, then usually we will essentially take the opposite approach of whichever operation they had before. So if that was a Heller myotomy the first time, and now they've developed scarring and recurrence because of that, then it's a safe and readily employable to do a poem the second time around and give them relief. And then so that, using the opposite procedure gives you a chance to go into totally clean new tissue planes and do the operation with the level of safety and reliability as the first time that you did the operation, as opposed to kind of, chipping through a reoperative field, which can be really hard to discern the planes and maybe put us at risk for other injury that we wouldn't have if it was a fresh operation.
Can I make a question?
Sure, absolutely, please. Sam.
Thank you. Congratulations, Dr. Pandya. Extraordinary conference, beautiful conference.
Thank you.
Taking the opportunity that Liz in the panel and is guiding you, I just want to make a quick question. Many countries, many of the patients with GERD disease are not studied totally. And many of them, they already done, were subjected to fundoplication. Some of them, the late diagnosis of achalasia becomes on. Do you have any experience, or you are aware of any studies with the possibility to do poem on these patients that they already had a short, floppy nissen and, became obviously a diagnosis of achalasia? If there is any experience? I don't know if my question was clear or not. Patients who were operated of GERD disease, had a fundoplication, a floppy fundoplication, and years after, they become that they had already an achalasia. So probably the first diagnosis was an achalasia and was missed by the first operation because it's similitude at the early stage, of symptoms. On those cases, if you demonstrate by manometry study, X-ray study, endoscopic study, that they have achalasia, it's valid to try to do poem on them and not to disrupt the whole fundoplication and do a Heller and do again a fundoplication? You think there is a space for it?
That sounds like a very complex situation. I don't personally have a lot of good experience about that type of level of complexity where the two are combined like that in a delayed fashion. From what I'll take a stab at it though, that, from everything that I've been reading so far, and assuming there's no like new hiatal hernia and other changes that need to be otherwise addressed operatively, it seems to me like poem could potentially still be a safe option. And you have the option of changing the orientation of your tunnel too. So if that is necessary to help steer clear of the.
Lee, if you have any experience with this.
Yes, Samuel, that's a great case. I'm sure you've seen it. I've seen it occasionally as well. My tendency in that would be not to do a poem, but take down the nissen and either do a myotomy and a partial fundoplication. One reason is a late occurrence, like you described, may be a dysfunctional nissen that led to secondary achalasia. So that would be a concern. And the second is that we know that 360-degree wrap for an amotile esophagus is not the best treatment. So even if you did a myotomy endoscopically, you'd be leaving them with a 360 wrap, and that probably doesn't add up. So I think in that case, I would tend to recommend to the patient that they have a laparoscopic procedure, take everything down, maybe do an EndoFLIP intraoperatively, do a myotomy if their distensibility was a little bit high, and then do a partial fundoplication.
Thank you
I'm
very
sure-
much, and congratulations again.
All right, thanks, Sam, for your question, and Dr. Swanstrom. So we have 5 minutes left. So I think if anybody has any questions, they can certainly ask them, but I'll give the last few minutes to Dr. Swanstrom just to kind of summarize from his perspective, from his experience, what would his pearls be in terms of the surgical management with POEM and for Heller myotomies, and what's the next thing? And 5 years from now, what do you think we'll be talking about at this webinar? Will be the same thing, or will be something new on the horizon that we need to be thinking about? And thanks again for everybody for participating. And I think we at least had 6 to 7 time zones. So again, thank you very much for everybody's time. Dr. Swanstrom.
Yeah, well, I'll once again just compliment Tejal for doing such a nice summary of things, and this for the Swedish group for leading and pioneering in this area. You know, POEM is really established. I can't think of any advanced centers that deal with achalasia that doesn't offer POEM. I think it's really withstood the test of time. Now it's almost 20 years ago, or 15 years ago, that was first described. You know, I think what's some of the really points that were brought out is the need for thorough preoperative evaluation, the need to offer patients an honest and unbiased choice so they can make a good decision, and then thorough and complete and objective follow-up. Because as Tejal pointed out, a subjective follow-up, particularly in achalasia, is almost worthless. And so we really need to do objective follow-up in these patients. And if you do that, give them an honest choice, and the patients do well. Achalasia patients after a successful treatment are one of the most happy patients I've ever dealt with. So that makes them a joy to operate on.
Very good. Think we kept everybody on time. Again, thanks again to Dr. Swanstrom, Dr. Pandya for an excellent talk, and all the best to everybody. Thanks again. Have a good evening or a good day or a good night.
Imran, I'll just mention maybe
Sure.
SSAT, the next session, the next webinar will be May 16th on robotics.
Okay.
And then the following one on June 20th on revision surgeries and bariatrics.
Okay, thank you, everyone. And hopefully everybody will join. At the beginning, I said there'll be about 10 people, but we hit 26 people in this webinar, which is pretty good considering the number of webinars people have to go to. Thanks again, everybody. Have a good evening, good night.
Thank you very much.
Bye.